What is up, everyone? Welcome to the Critical Care Lounge. I'm joined, as always, by our ever-bubbly host, Dr. Adam Green. What is up, my man? Oh, hang on now. Hang on. I cannot hear Adam Green. Hang on. Oh, I think I know the problem. Hit me now, Adam. Still can't hear you. Let us see. Let us see. Give me a second here. Oh, got it. What's up, Adam?
Am I back?
You are
I'm
back.
allowed to speak. I'm allowed to speak.
I had to put you on mute, Adam, because we've had some complaints about your outbursts that you have during the
Yeah,
show.
this was a demonstration of a new feature we've added at the show, where when our guests or myself misbehave, Haney just puts us in timeout for 10 seconds.
That's right. It's called God mode, and I
Yeah,
am in control. Adam, how you been?
I'm good, man. I'm good. Just enjoying the cold weather and living life. How have you been?
I've been really, really well. I've gotten in my steps. I've gotten in my shovels. I've just been doing a lot of plowing of snow this past weekend. So I'm glad that I am not at home, that I'm in the studio, ready to bring a show, which I think is going to be maybe our best show ever. Are you excited?
I'm excited.
All
What are
right.
we talking about?
We are talking about Airway, but it's more than that. It's more than that because today we don't have one, we don't have two, we have three Airway gurus on who are going to be going through some cases. Let me bring everyone on. And what is up, boys? How's it going? We have Chris Potestio, we have Steve Haywood, we have Terren Trott. Gents, go ahead and introduce yourselves. Chris, why don't you go first? Tell the people who you are. Chris, can you hear
I'll
me?
go first since I'm leftmost on the screen. I am an anesthesiologist and critical care doctor at Cooper Hospital, Camden, New Jersey. Um, I'll leave it at that for now.
Nice. And Steve, tell us about yourself.
Hey guys, I'm Steve Haywood. I'm an emergency medicine physician in Corinth, Mississippi. I just moved here, just started this job. In a previous life, I was a respiratory therapist and I did respiratory therapy for 8 years, worked in a large facility where we primarily did the airways, but we were not allowed to use paralytics, which made them challenging. And I use paralytics now, spoiler alert. But anyway, yeah, that's me.
Great. Dr. Terren Grandpa Trott.
Yeah, I'm Terren Trott. I'm an avid gardener. I'm really looking forward to spring. I'm going to put some bulbs in the ground. I'm going to probably Snapchat them or Instagram them daily
I'm going to have to mute him because that's just nonsense. No, I'm just kidding.
with
Go
me.
ahead.
I do EM and critical care at the University of Kentucky.
Very good. And he's a bourbon enthusiast as well.
That's right.
I do enjoy hanging out with Terren. All right. So what we're going to do today is we are going to present to you cases. They're going to be video. They're going to be cases of video laryngoscopy. Terren has provided these cases, so he knows what's there. We're going to just introduce the vignettes to you, just a sentence of a vignette. And then while we're watching the videos, and we're all going to watch the videos together, and then I just want you guys to go at it. Tell us the things that are good about the case. Tell us the things that are bad about the case. And don't worry, Terren didn't do the airway, so you can offend no one. The person who watched it is not who did it is not watching. So, unleash fury. But the point here is recording this process is very helpful for people to get feedback on how they're doing, and by watching other people's airways, you can improve skill sets. Because let's face it, in the heat of the moment, we've all made these mistakes. Adam, what else do you have to add about this? What are you looking for in tonight's cases?
I'm going to tell a secret. I reviewed the cases, and every single one of them scares me. And I'm just excited to see the fear in these guys' eyes as Terren unleashes the brutal airway.
Yeah, and I'll let you guys know. I mean, for everyone that's watching right now, what you know is more or less what we know. So if you want to know details, like what was this scenario, what was that, we probably don't know. So we're all mostly taking it at face value, except for the very limited information in the vignettes. So we're kind of just tackling it and see where we get to.
Now, I want to tell Adam mostly this. I told you I was going to present the first case, and of course, as I was doing all the audio, I don't have the first case ready. Do you have the first vignette ready to go? And I'll do number two.
I can just present them all if you want.
No.
Um,
Let me
I'm ready to go.
Okay.
All right.
I
So the
think he
first
wants to
case.
present them all.
Oh,
you know,
yeah.
Adam, you do them all. Okay. I'm just gonna sit back here and monitor the chat, and then you take over. All right. I'm gonna give you guys the first case. Now
This
listen.
is to get even with the whole blood lecture, the whole blood episode where I was on mute the entire time.
That is fair. That is fair. This is your time to shine.
What I only have a brief like 1 or 2 sentences about each case, and Terren can add details if there's things that he thinks we should add. But so the first case is a 29-year-old.
Oh, hang on now. Hang on. I know you're really excited. You're like
I'm
ready out
really
the gates.
excited.
All right. So here, folks, this is always interactive. Please put your comments in the chat. If you have questions, please put them in. We want to read. And don't forget this one thing. Like and subscribe to the channel. We're actually almost at 10,000 subscribers as of right now. So get us over the edge. Like and subscribe. We'll show up in your feed. But please, this is interactive. We really want you to be part of this. Blow up the chat. Okay. So with that, Adam, you ready?
For real this time?
3, 2. You ready? 3. You're ready.
Yeah.
Go.
Okay. So 29-year-old comes in with Stridor. Initial saturation 88% on non-rebreather. Decision made to give RSI and intubate.
All right. So any one of you just take the case and just give us a little narration of what you're seeing and your thoughts about what, anything at all.
I'll start by saying I hate that that premise. Stridor is always a escalation of concern for me. So the fact that we're already doing RSI in a patient with Stridor, I'm nervous.
Yeah, I totally agree. Like I said, I grew up not having the option of RSI, and it usually, I love RSI, except in these cases. Allow the patient to continue breathing. If they can protect their airway, allow them to protect their airway as we slowly go through this thing. Because if all they got is a little coffee straw getting air through and we lose that, we may be escalating to cutting the neck a lot sooner.
Chris,
yeah, and her age, her demographic kind of like put some things in my mind. I'm thinking it's probably angioedema. It's probably something like that, anaphylaxis, less likely to be a massive tumor that's been unaddressed for, 6 months or a year. But I think, if you have the option, an awake fiber optic is definitely the way I'm going to go. It sounds like we obviously missed that window with this patient.
Yeah, I will play devil's advocate and say, I just watched a successful intubation, so I'm not worried from that perspective. But if a person has Stridor and are moving air, I feel like RSI with the aim of introducing a small endotracheal tube is it's an okay first plan. And I don't know, I would be hesitant to do an RSI in this patient because technically it's more difficult to put a breathing tube. Like, yes, you're preserving spontaneous respirations and you may buy yourself more time. But you can see in this video, we're using a lot of force to get the tube through the airway. And if you're sliding it over a bronchoscope, it's hard to push with any force. And I could anticipate some issues in the moments of passing the vocal cords with the fiber optics versus sort of just biting the bullet, using ideal conditions for first pass, like good anesthetic induction, good paralytic, and just giving yourself the best chance for securing the airway.
Chris, can I ask you a question?
Yeah.
Is that a Peloton bike in the background? Are you worried?
It is a Peloton bike. Mint condition, barely used. I
don't know if you're going to get the resale value of it. The Peloton is not doing well these days, just so you know. I just want to point that out to everyone watching at home. Okay, so let's go ahead. Let's go back, and I want you guys now to point out from the jump things that you would have done differently. I certainly have some comments, but it's not about me. It's about you guys. What do you guys think? What do you think about this approach right here, going towards the sort of the posterior, the tongue, and this look right here? Anything you would do differently, or you think it's okay? Terren,
So
what
I
do you
mean,
think?
we enter the mouth from a lateral approach, and people debate whether or not if you're using video, it should be a lateral or a midline approach. And I think honestly, either is going to be acceptable. If you have a tongue that starts getting in the way, you're going to have to address that one way or another, whether it's midline or lateral. I think if you take a lateral approach, you can probably push the tongue out a little bit more. But then again, one of those big floppy tongues likes to swing around and get in your face anyways. So, if the tongue's going to be a problem, it's going to be a problem. You're going to have to address it. This person took a lateral approach and did a pretty good job of, working down towards the vallecula, which,
Mm-hmm.
slow is fast, right? But then we do kind of get a little off axis once we really enter the vallecula.
Yeah, Steve, what do you think about this right here? Because I don't know, this person seemed to deploy the tube. At this point, do you think this is the best view that they could have gotten? Obviously, we weren't there, but what would you have done different?
Sure. Well, like Terren was saying, when we're kind of off axis, when you hit right midline in the vallecula, you engage that hyoepiglottic ligament, which kind of flips that epiglottis right up and just gives you a clear shot of the cords. And sometimes when you're coming off axis, you can miss that midline, or you cannot get all the way back into that fold and engage that ligament. So again, I agree with Terren. They found the back of the tongue, they found the epiglottis, they found the vallecula, they made a stepwise approach. But coming that lateral approach, if you can just make sure you get into that fold and maybe flip that up a little bit more. But patient with Stridor, you've got adrenaline as soon as you see cords. I probably would have deployed the tube too, with the adrenaline pumping, like I'm sure this proceduralist's adrenaline was.
What do you
Yeah, I think the other thing we're all probably catching is there's a lot of hang up on the anterior trachea as the tube is trying to pass. Yeah, right here. I mean, we're seeing the person struggle quite a bit. I'd be curious I think we get the proper turn, the little bit of 90-degree rotation, and we see it pass. So I think that was employed properly. But this kind of anterior hang up we see over and over, and I can't help but think that it has also something to do with improper positioning. Like if maybe we're in a little bit too much of a neck flexed position, so that when you come up with the tube, you're still kind of anterior. I think it keeps crossing my mind. I think we don't take as much time as we should to position properly.
Terren, what blade do you
Yeah,
think
I
this
agree with
is?
that actually.
It it looks probably like a video Mac blade, right? I mean, do you think
Yeah,
if you used a hyperangulated with a rigid stylet, you would have a better success?
I'm sure there's a study somewhere I could quote for that, but I don't know.
I'm just looking at this view. I'm looking how close they are. I'm looking at. You're right. The tube deployment in video when you're this close to the airway can be challenging.
Yeah, it's hard to know where you're going to enter the screen when you
Yeah.
are super close. Yeah, that's true. Chris, you were going to say something.
Well, I'll say a couple things. One is that my favorite part about this intubation is that it was slow and careful because there's a lot of swelling and a lot of friable tissue. Terren, when you were talking about being hung up on the anterior trachea, I was assuming actually that they were hung up on the vocal cords just being sort of opposed and tight,
Yeah, maybe
which
they
I
are.
would
Yeah.
expect in a Stridor's patient. And to my first comment, like that's where having a rigid stylet and being able to sort of force your way in is useful. I am the anesthesiologist of the bunch, and I'll say like that first grade 3 view that we saw was enough for me to intubate this patient. I wouldn't be trying to get a perfect view in a patient where I know I have limited time, and I would feel pretty confident with that first grade 3 view.
Good point. Comment from Randy, who's always a great question person. Of course, I blocked it behind, but Randy's question says, "I like the first best attempt answer. Curious about who would use a bronchoscope based on what we heard from this presentation. Who would have done an approach, not knowing that this is what you were going to find? Oh man, that's annoying. Not knowing what you were going to find, but who would have gone with the bronchoscope first, just based on the history and the way the patient's presenting themselves?"
So I'd say I had a similar case at a freestanding ER where I had no backup. It was just me. And I did start with the bronchoscope. But the other thing that I did that we hinted at earlier is I had my paralytics drawn up and I was using high dose rock. So it would hit the patient immediately. So as soon as I got the bronchoscope through the cords, pushing paralytics, and that will, calm them down, relax everything, so that if I'm hitting that hang up on the cords, I've got my track secured with the bronchoscope. As soon as I've got that track secured, go ahead and paralyze at that point, and then I can get my tube through. So that's kind of my go-to for these scary upper airway obstructions.
Fantastic. Anyone else have any thoughts?
I have one more
I mean,
question. Oh, go ahead, Terren.
there's
You
a,
go.
when you have someone that's, essentially as best pre-oxygenated as you can, say they're on BiPAP or being bagged and you can only get them to 88% with Stridor. I think the next real big, am I able to re-oxygenate this person by bagging? That's a huge determination. If yes, I'm going to start leaning more towards fiber optic. If no, it's going to be RSI and prepare for surgical airway, or LMA, surgical airway. And then the other major factor for me is going to be work of breathing. If someone's just chilling, like super comfortable, which maybe we've seen we've all seen maybe some paradoxical vocal fold motion patients that kind of fit that picture. They can get a lot of Stridor, but the stats are actually 99% work of breathing. There's this myriad of things that have to go into that decision. If you have someone that's stable, it's going to be fiber optic for me every single time. But if you have someone that's unstable and actively declining, RSI, first pass success, and prepare to do a surgical airway. But, I had a patient about 3-4 weeks ago who, after only one prior intubation, had, unbeknownst to us, developed some of the worst subglottic stenosis ENT had ever seen. And, so this was a could not intubate from above patient, but we were able to maintain oxygen with LMA to 89 and went to the OR. And if we had tried a surgical airway in this Stridor, we would have been screwed. So I think it's definitely knowing your algorithms and knowing what kind of backup and assistance you can get. Super important.
Great. So I want to make sure we get to all the cases just to show you Randy approves. Okay? Randy likes that answer. Okay?
Hey.
All right. Let's go on to the next case. Adam, you ready to go? And we do have comments.
Yeah.
I'm going to catch up with them later, but I want to make sure we have 4 cases. We may not get through all of them, but I want to make sure we get to at least the second case. All right, Adam.
Case number 2. Here we go. So 68-year-old, cardiac arrest, ROSC after less than 10 minutes. PEA, oh, I'm sorry, I read wrong. Less than 10-minute downtime, and PEA would they show up. No prior history. That's all we have.
All right, so who wants to take the first crack at what they're seeing? And even if you just talk us through what you're seeing, that's fine.
Well, that's not a breathing tube, personally. No, there's a lot of secretions and stomach contents in the posterior pharynx, and it's scary, but I don't think it changes your. It can be more of a distraction than it can be a help. I think I see a good pathway to the airway, although I don't see a lot. And I see the bougie intubation that looks to be successful, but sometimes in this situation, it's kind of blind and you don't know.
That's a super good point right there.
Yeah, I appreciate that you need to suction the airway, but I would caution it being too suction happy, and I would hurry up and intubate. As the video goes, we're getting. I think we have a esophageal intubation.
Yeah, I think I just saw that too. Bad news. Yeah, that's. I think this definitely highlights the debate between intubating, because now we've just delayed the time that this patient's not getting oxygen, or ventilation. And I totally agree.
When you look
Chris,
right here, this is a great view. I was just going to say, this is a great view right here. This looks like about where they deploy the bougie, and you can clearly see the vallecula, and the blade's not in the vallecula. If you just advance it a little bit further and get in the vallecula, that's going to displace the epiglottis and allow you to actually see behind it.
See, yeah, the blade definitely needs to go a little bit. What we just saw in the last 10 seconds there, it would have convinced me the bougie was going the right place, because we actually see that little traction, that little bit of a tug on the epiglottis, which, I don't know what the metrics are, but it makes me think that I've engaged the glottis. Something's kind of tugging on it, and it kind of usually reassures me. But clearly, that wasn't the case here.
Yeah, I think they were totally distracted by suction and didn't spend enough time doing laryngoscopy.
Yeah.
Mm-hmm.
Looking at it, I agree with Chris. One thing I see consistently is
there it is again.
the more emergent the situation, the quicker the time the tube gets deployed. So whenever you see anything that resembles airway, the more stressful it is, someone wants the tube. Versus just taking really probably only 2 or 3 more seconds to optimize your view. I agree that if this was advanced a little further, you would have engaged the hyoepiglottic ligament, pulled up the airway, and maybe had a better view. Now, you may not have seen everything because of all the airway secretions and frank pooling of secretions, but you might have seen more things to have deployed your bougie. And then the other thing personally for me that I might have done is, this is where, if you have a 2-person, or I should say a 2-suction setup, or even a 1-suction setup, where you're getting it and you're parking in the hypopharynx, that suction, you ask your assistant there, just hold this right there, just continuously holding suction, so you just continuously clear the airway as you're passing. Maybe that would have helped out.
Yeah, depositing the suction in the esophagus in this instead of maintaining it, yourself would have been great, or giving it to a friend. I think I would have had like 3 or 4 people at the head of bed to assist with this intubation. I'm a big fan of like having that first year med students who's already about to like vagal out, hold the head really still for you in a good sniffing position. And that for me helps a lot because the chest is moving. Sometimes you get a lot of activity, and if you can just stabilize the head, it can make you really focus. Like, this is actually just another intubation, get you in the right mindset without things flying everywhere that inevitably happens sometimes.
Any other comments, Steve?
So did the vignette say this patient was actively receiving CPR?
Yes.
Do we have that?
Yes. Yeah. It says it's correct. It doesn't look like it based on the movement of the camera, but yeah, that's the vignette.
Right. It's a great, throwing LMA so you get Ross. You get the LMA with the section of the distal port. Because all you did here, I agree, it does not look like they're getting chest compressions. You're probably delaying compressions, which save lives, and then you goose the tube anyway. So,
yeah, I think it's tough though, right?
Situation.
It's tough if we think that this is primary cardiac arrest that's respiratory driven. I'm all for the LMA, but this is a drowned airway. You got to get the tube in.
Yeah. The other thing is I've run into the issue with bigger patients, taller patients, where if you attack them with a Mach 3, you get to where you see the epiglottis, you see the vallecula, and you just can't get to it because your blade's not long enough. So I don't know. This may have been the issue. It may have been a really tall patient, and this was a Mach 3 blade, and that's as far as they could get it in, and they just couldn't get it to the vallecula.
Steve, I feel like you're making a case for a Mach 4 every time. Is that what's going on here?
I'm a Mach 4 guy. If I can fit it in there,
Mach 4 guy.
I'm paid by the Mach 4.
I'm a Mach 4 guy.
Just so you know, you didn't disclaim that at the beginning. But
yeah.
Really, I'm gonna actually say that I'm not a Mach 4 person.
Hey, what?
Hey, I'm paid by the Mach 3.
Somebody mute him.
Be careful.
He has God mode.
Well, here's my thing, right? Because I know people say, here's the common things I think, or I hear. Well, I go in with the Mach 4, and I can use it as a Mach. And if their epiglottis is big, then I can go in and turn into a Miller blade. See, that could work, but the problem is the flange of a Mach 4 is significantly bigger than a Mach 3, and you're actually decreasing your visualization. And most people, unless you're intubating basketball players, probably could be intubated pretty well with a Mach 3. So I'm much more of the mindset that most people that I'm intubating, unless they're 7 foot tall, I'm going to start with a Mach 3 and take a look. If their epiglottis is heavy, I'm going to ask for the tool that will help me with the epiglottis, and then I'll go ahead and lift the epiglottis. If I'm intubating someone right off the bat who's very tall, I'll ask for the Mach 4. But I find that the airway opening sometimes is not big enough to visualize. If we're talking about direct, maybe when you're using video, it's a little different. But when you're using direct laryngoscopy, which sometimes you can, or you can make the argument that with this much soiled airway, that's going to go on the camera, and now your video is essentially just direct. And again, that opening, that flange on that Mac 4 is going to decrease the amount of visualization that you have. So that's what I got to say about that.
I'm a side with Haney on this one too. I'm a Mac 3 person.
Oh my gosh.
I'm sticking with my Mac 4.
I
Mac 4.
I ask for one thing. Can we compare flanges next time we see each other?
I don't know if that's
Because
appropriate.
I'm not buying it.
I don't know if that's
Chris, you're quiet. What's going through your mind? You just thinking these crazy intensivists, they know nothing about airways.
And don't say Miller. Don't say Miller.
No, I don't use the Miller. I don't care that much, honestly, between Mac 3 and Mac 4. I don't have a strong opinion. I think they both work. In extremes, you can make the case for either. The normal patient that's a normal size, you could probably do both.
Yeah. All right.
The
Well,
expert has spoken. There you go. All right, next case.
But
Good
but I will
night.
show you next time. I mean, this is one of my favorite things to do is after an intubation is take the flanges and with the residents or fellows just show them how big. And most people who are like, yeah, Mac 4 for life, son, and then they actually look at it as like, oh, respect to the Mac 3. All right, next case. Here we go. Come on, computer.
All right, I'm going to focus. All right, so 50-year-old hemorrhagic shock, presumed secondary to a GI bleed, arrested prior to arrival, now with ROSC.
I'm going to start over again because I think right from the get-go, I think the thing that was distracting everybody. You're just watching this and you're like, come on, buddy. Come on.
There's a lot of soft tissue. This supraglottic space has a lot of soft tissue that a person had to navigate through.
Yeah.
This is like what you hope to see when you have a hemorrhagic shock patient. Because honestly, we all know it could be so much worse.
What I'm wondering here is like, why bougie?
From the jump, right?
What's that giving us right there? I mean, you have like a grade 1 view. I don't like if the only time I would use a bougie is if I'm not seeing the vocal cords or if it's like very anterior and tough to pass. This I would have been set up just to intubate normal. Let's try that.
So interesting. Maybe we'll get back to case in a second, but I'm curious who here reserves bougie just for difficult views, or who approaches some airways with even grade 1 airways with bougies. I mean, there is some data out there, right? The driver stuff that says that maybe bougie is good at a first attempt in emergent airway. I'm just throwing it out there. What do you guys think?
So I will say, before I left my last program, I had one of my PGY2s, and we were just playing around with the airway head, and he was a PGY2, and we talked about the bougie, and he's like, I've never used one. And he just deployed it on the airway head, and he couldn't figure it out. Like, it took him a good 5-10 minutes of playing with it to just kind of, and I don't know, it may have just been a coordination issue with him. But especially with my ER residents, one day a bougie is going to save your butt. And I don't want that to be the first day they've used bougies. So I encourage them to use bougies, have, the Kiwi grip with the tube already in there. It doesn't really slow you down at all. And if you get into a situation where you've got to have it, you're very proficient with it. And they may be doing 10 tubes a month. They're not, they're not sitting. If you're using, obviously sitting in the OR, you'll get a lot more tubes than we do. And so you have the opportunity to be proficient. But especially with my ER residents, I want to make sure this is something that they are skilled with. So I do encourage them to use it more frequently.
So you're saying, from a training perspective, it would be a good idea to use bougie on the first attempt, no matter the visualization of the airway.
Yeah, absolutely. And especially if they're going to have limited opportunities to intubate, you want to make sure that you're competent with all of your tools. Sure. And so it's a great way to maintain competence. And I don't think there's any risk to the patient, any risk of harm. Yeah. And potentially, again, it was a single center trial, but the driver paper showed there may be benefit to our patients.
Yeah. I don't agree with you. I don't disagree with you from the training point of view. Let me ask everyone else, who's using bougie on a first pass for the majority of their tubes? Like, it's you alone. You're feeling really good about intubating people. You have your Mac 4 because that's what you've been brainwashed to use. Now who's gonna use the bougie as their first attempt?
You know, I'll tell you,
if
Haney,
I have any resemblance that this could be a difficult airway for any reason, I'll grab a bougie first. If it's like someone satting 99 prior to pre-oxygenation and it's like a mental status thing, and I have no predictors of a difficult airway, I probably won't take the time to be fully honest. But you know, if I'm worried about secretions or anatomy or body habitus, any of the numerous factors we know are associated with difficult airway, I'll usually start with the bougie and just use it as my stylet.
Adam, you were saying?
Yeah, so I'll say my goal is to approach every airway the exact same way. So, I like to tell all the residents and fellows that, Chris and anesthesia are airway experts. In no way am I trying to be an expert. I'm not trying to master a million tools. I have no desire to be able to intubate 100 ways. I want to approach every single airway the same way every single time. And to me, that means for the most part, it's going to be video, no bougie. Does it mean that every now and then I practice a skill? If it's a slam dunk airway protection, I just want to make sure that I'm still proficient while I'll deploy it. Sure. But for the most part, I do not.
All right.
I was thinking, I don't know if I've ever used a bougie on a first pass. I've used it as a rescue device, and it saved my butt, like, I don't know, maybe 10 times. Certainly saves patients' lives. But I'm sort of more in the Adam Green school of thought in terms of, like, I just want to do what's normal, and what's normal is normal for a reason. But to your point about training, I'm glad I'm proficient in it because it certainly has a role in my airway management.
All right. Sounds good. Anyone else have any comments? Kind of looking at this one last time. I'm going to throw up some comments. Randy never disappoints. His comment on the 4. All right. So 4 for him.
Hell yeah, Randy.
For those of you who are Millers fans, Ian London says no gracias. And Randy again, back with the what's with all the bougies? I gotta meet this Randy guy.
I will say on that.
When am I gonna meet this Randy guy?
That first airway.
Go ahead. I'm sorry, Steve. Go ahead.
No, I was saying on that first airway with the angioedema. If you're not going to use a bronchoscope, I actually like the bougie there because it looked like they started with a 602. But if you get your bougie in and you started with the 7.5 and you can't get the 7.5 in, you don't have to go through it all again. You just take the 7.5 off, you load your 6.0, and you've got your track secured. So on that first airway with the angioedema, if you're not going to use a bronchoscope, especially if you've got pediatric tubes, smaller tubes, you may have to go to. I do like a bougie there.
All right, amigos. Anything else before we move on?
For all you bougie people.
Bougie people. Y'all bougie. Y'all bougie. All right. Here is your final case. I'm just going to stop. I just got to stop for a second.
Oh.
This guy looks like... What is going on with... Is this a burn patient? Adam, give me context. What is going on with this guy? He does not look well.
Oh, that question was directed at me. Sorry. So 31-year-old... motor vehicle collision, intubated on the scene, GCS 4, initial BP 68/31.
Okay.
Rough.
So that's maybe some facial burns from the airbags deploying or glass on the scene or just something, but that explains all of that.
Yeah, that's a lot of blood.
That is a lot of blood.
I don't like that blood pressure either.
All right, I'm going to start up again so we get a second look at it.
I'm wondering why we're doing a video laryngoscopy. I guess maybe to examine the airway in this one for injury.
So your question is why video and not just direct? Or what would you do?
Isn't the patient already intubated?
So maybe I should provide a little bit. I was really curious what you guys want to say about this one because this person had been nasotracheal intubated in the field. And so I think maybe that should have been part of the vignette there. Yeah, because I think it's totally reasonable to try and confirm that too. I mean, obviously you should have a good waveform, a good end-tidal CO2, etc. But we know that that's not necessarily going to be a completely secure tube. Maybe it's just like right at the glottis or something like that. So I'm presuming that's why this person went for video laryngoscopy.
The other reason is if they use direct, we would have no case.
Captain Obvious over here, right? No, that's a
Yeah.
good point. But let's look at it. So this person's going in with video. Well, you know what? Actually, let's talk about it then. How many of you, because I certainly have my answer, if you're working by yourself, how many of you would use a standard geometry video for every case, regardless of what the presentation is? Show of hands. Okay. So then, who didn't raise your hands? I didn't see with the screen. It was Chris and Terren?
No, I raised my bourbon. I'm sorry.
Oh, you raised your bourbon. Okay, so Chris, tell us why you would not do direct on every view. I'm sorry, why you would not use video for every approach. Standard geometry, not hyperangulated.
My patients are a little different than I do a lot of elective cases, and that's probably why. In the elective world, it's just easier and faster, and uses less resources.
Well, you know, you're also an intensivist, so now you're taking care of this person. They're somehow made up bypass the ER, or the ED calls you down to see this person. If this were your case, would it be video first, or would you still say, I'm going to take a look with direct first?
You know, the way I learn is that when there's a bloody airway, don't put a camera in there, because the camera will get bloody and you won't be able to see anything. I mean, obviously, we've looked at several videos that were like full of stuff in the airway and it didn't block the camera. So that may be a little bit like a fool's wisdom. But that's my thought is like, you know, I'm always thinking to myself, how do I optimize my first view? Because, you know, laryngoscopy of any kind, limited resource. We don't want to be, we want to have our best shot first. And so that's, and I think when there's concern for, especially blood, but any other like fluid contents in the pharynx, then I want to see with my eyes and not camera.
Steve, Terren?
So yeah, I think that's where so when I started, their only video was the hyperangulated, and I've been there where, you know, they cough a loogie on your camera and you're toast. You have to abandon the attempt. The standard geometry video blades, I think, have been the game changers. And especially my resus bay, if this is a trauma and there's a discussion going on about whether the tube's in, if you can put it up on a video screen and let everybody in the room see, yes, there's vocal cords wrapped around plastic, that puts it to bed. And then with the standard geometry, I can go in there with the video, and if that blood gets on my camera, that's fine. I can do direct laryngoscopy with it and do what I always do. So yeah, with the standard geometry video blade, I'm okay in a bloody airway. Now, a hyperangulated video blade, I'm not going to use that in a contaminated airway, because if you get a little fleck of something on your camera, you have to completely abandon that intubation attempt.
Terren, before the all the bourbon sets in, do you have any other comment? Because you've been drinking pretty.
Yeah,
heavily.
you know, I wish I had some. There's one studies by Sackles about the ratio of how often a soiled airway actually contaminates your view, whether it's video or direct. And basically, you're kind of screwed either way. Is the short note of that study. I mean, somewhere it was like 66% of the time you were able to get a view in a contaminated with video, and they said only 45% of the time you're able to get a view contaminated with direct. And after reading that, I really kind of like reevaluated, because I'd always had this mantra: you soiled airway, I'm going to do direct, for the same reasons we've all been taught. And you know, over the last couple of years, I've really second guessed that, knowing that there isn't, you know, there's some very intuitive reasons why that is probably true, but I'm not as convinced of it as I used to be. And so I don't really have a major pause, especially with a standard blade, standard geometry blade in a known soiled airway to do video. And I find that very often, if my view is obscured, it's obscured very briefly, and I'm still able to, you know, get what I need out of the screen and get the patient intubated. You know, is this going to let me down one day? I'm a little nervous, of course, but that's why we like the standard geometry blade.
Nice, well said. Even slurring your speech, you managed to get that out.
That's just my southern drawl.
Nah, you say that, but I've heard you sober. Okay, so let's see. This is my favorite comment of all the comments. It says, "Good point, guy in the middle." There you go.
Ian,
Oh.
we can be friends.
Guy
Also known as Cowhead.
guy in the middle. Okay. All right. Let me turn it out to the audience, please. You've been blowing up the chats, and I really appreciate it. But go ahead and hit us up with some questions. This was our last case. We're going to wind it down. I just want to go through each one of the cases, the salient points that we took home. I want to summarize because you guys, look, the best part about all this is you have, one emergency medicine person who used to do, one emergency medicine doc who used to do respiratory. You have an emergency medicine and intensivist down the bottom corner. You have an anesthesiologist who does intensive care who's seen a boatload of cases. You got Adam, who's a critical care doc who intubates in the most dire situations. Everyone has their own perspectives, and no one's walking away from here saying anyone's right or wrong. It's really for us to learn from everybody else's techniques and hopefully pick up some salient points. So I'm tremendously grateful that you all were here and you commented, because I learned a bunch from you. But I want to go back to each one of these cases as the comments start to populate in, and review each one of these cases. So remember the first case right here. This was the one where the person kind of went a little bit lateral for the airway. And I'm going to just summarize the points. Tell me if I miss anything. We said maybe you'd be a little bit more midline with this person. Maybe you'd go a little bit further and engage that hyoepiglottic ligament, because the visualization here is maybe not so great. And as I recall, there was a little bit of a hang up, right? As we were getting in there, either the anterior trachea or the cords, a little bit hard to see. Maybe it is the cords right there. It's kind of locked up in there. But any other points that y'all had about this? The Mississippi's.
So if you're hanging up on the cord, if you're hanging up on the cords before you go through, 90 degrees to the left is going to put that that curve of the tube to allow you to slide up in the cords. Once you're through the cords and you're hanging up, if you're hanging up on those tracheal rings, actually going 90 degrees to the right is going to put your ramp to where you'll slide over those rings easier. So if you're in front of the cords hanging up, go 90 degrees to the left. If you're through the cord hanging up, go 90 degrees to the right. Little pearl for you from the guy in the middle.
Good point, guy in the middle.
With the cow behind him.
Terren or Chris?
Yeah, that's good. That's a good point.
Yeah. I'll add that in this video, we're pointing directly into the right piriform sinus. And so I bet if we looked at this person, if we took 5 steps back and looked at this person, they would very clearly not be midline. So friendly reminder to, when you're stuck, you don't have to be buried in the airway. Take a step back and see where you are, where the patient's anatomy is.
Yeah. Great point. Yeah, I see a lot of us when things are getting a little tense or new airway people. You tend to go right up into the airway, and taking a step back and assessing the situation, you'll give you an idea of if you're too far left or right. And I agree. This was a little bit too far off the midline for me. I think in the middle we would have had a much better view, and also you would have had a much better lift of the soft tissue. There'd be something to lift up if you did that. Terren, anything else?
That's good. I like it. I mean, in the angioedema, I think I would reiterate Steve's point. I think bougie first and the angioedema and Stridor is pretty reasonable.
This guy in the middle, not Steve anymore. Okay.
Next
case right here. What are the takeaway points from this case? This was the massively soiled airway. Things again that I took home is, we're having a little bit of a difference of opinion as to whether or not we're going to do aggressive suctioning. But some people are saying they would kind of park a suction catheter, maybe even dive it into the esophagus, maybe just have an assistant hold that suction right down in there while visualizing the airway. But I think we can all agree that this view is not optimized, whether you suck out all the secretions or not. We're not seeing really any anatomy, but there's this impetus to get the bougie in, probably a little bit too premature. Any other comments?
I mean, I think you really got to know your tube confirmation devices, because I think we all were kind of led to believe this was probably in the right space. It wasn't. And, hopefully, the sooner you trust your tube confirmation devices, the sooner you pull that. If you hadn't seen it on the video, 20 seconds
since
later.
You mentioned it, and that we do have some junior learners on here, what tube confirmation, what is from the order of least to most accurate for you? To confirm.
I think most accurate is going to be your waveform capnography.
Okay.
And right below that is probably going to be your colorimetric device. And those two combined, if you use them in series should give you a pretty high 99.9% tube conformation. And that's, there's some caveats to that, low flow states, and, making sure that you actually have this 4-phase waveform on your capnography device, definitely mandatory. And there's a couple exclusion events, but I think if you have both of those, you're in good hands, and trusting that. So, if you're not getting color change and it's been 7 breaths, you're probably not in the right spot, acting on it appropriately.
Steve or Chris?
Yeah, I agree. Trust your devices, and don't continue to say, I think it's in. It looks pretty good.
Yep.
I thought I could see it go through the cords. It's like trust the technology.
Yeah.
Yep.
Trust the technology.
Maybe with the bougie, we talk about the clicks. Oh, sorry.
No, go ahead.
Me? Oh, okay.
You
The other thing we
got
talked about on the clicks of the tracheal rings, especially if you got ongoing CPR, you got this huge rush of adrenaline. You may not feel those clicks. The other thing you can do is, if you're questioning whether you feel those, just keep advancing it. And when you hit the carina, you should hold up pretty stoutly. And we call that the hold up sign. So if you pass it, you think you're through the cords, you can go just a little bit further and you're hitting a lot of resistance, that's a really good sign. If you're like, I think I'm in, let me just advance a little bit more, and it keeps going and going and going, you're just plunging that guy down the esophagus and you're not in the trachea. So in a perfect world, you can feel the clicks. And if you can calm yourself, you very clearly can get that tactile sensation. But if you've got the adrenaline going and you're doubting yourself, just keep advancing it and seeing if you're getting that hold up sign. And if that guy just keeps going and going, you're in the esophagus. You're not in the trachea.
Fantastic.
Yeah. So my one comment, Terren, was going to be trust your eyes, right? Because we've all had those cases where we're sure we're through the cords, right? And you put that end tidal CO2 that has been exposed to the air for 12 minutes and is 14 years expired, and they put it on there and there's no change, and someone yells, "Pull the tube," and we know it's in, and so that's when I listen, that's when I stop, that's when I reconfirm. I think sometimes we just need to trust what we saw more than anything else. I don't know if you agree.
Yeah, I don't know. I've been on both sides of that equation, because I've definitely been with residents who are doing direct while I'm watching video, and they said, I saw it go through the cords, and I'm like, no, you did not. I know exactly where that went.
Yeah.
So maybe
Good
with
point.
the right experience, for sure. But there's a reason we have multiple stops to confirm a tube, and why we should never miss
Sure.
a incorrectly placed tube.
And I think going back to that trauma case, we talked about, if there's a debate, if you've got a video blade in there, just pop it back in the mouth and show everyone, show those cords wrapped around tube, and that should put it to rest. And the beauty of VL is it's not me looking in there saying, yes, I'm sure. It's everyone in the room looking at that screen and seeing that tube through those cords.
Very good. Quick question from Ian. Would you use salad in this case? Terren, by the way, has an amazing salad simulator.
Yeah. I think that's a great, this is a suction-assisted laryngoscopy, airway decontamination. It's a mouthful, which is obviously salad. And that's an approach where you're using your suction catheter first to decon the airway, leaving it in the esophagus to, prevent further aspiration and contamination of your view. And I think if you're trained in that, and this would be a 100% appropriate time to deploy it, for sure.
I do have to comment that SAL is one of those acronyms that someone was really struggling to make into an acronym, just so you know. All right.
And that's from Jim Ducanto, if anyone on this wants to.
Great educator, Jim Ducanto.
Yeah.
This case. So this was the one where just that bougie just isn't making it in there. And one of the things we talked about is whether or not bougie was the right choice as a primary airway for this person. One thing, as I'm watching this, I didn't bring up, but I want to ask you guys is, external laryngeal maneuvers. I'm not seeing, now it's hard to see on a video from the inside whether or not it's happening, but, for those of you at home, doing external laryngeal maneuvers is essentially when you don't get a view that's just perfect. Rather than doing cricoid pressure or old school BURP, you actually just push the airway down and manipulate it from the outside using the cricoid cartilage until you get it into view, and then asking your assistant to hold down, I should say the thyroid cartilage, my mistake, holding it to where it's in view, and then you have a much more straight shot. I think that would be my comment for this airway, but how many of you are using that as active, like in this airway right here, where we're not really getting a good view? I think we can agree. How many of you would have used that on this to move things into view? No one. Great. Good. Thanks, guys.
No, every single time. As soon as when I'm adjusting to get my view and I haven't grabbed the tube yet, my right hand is on the trachea. I'm moving, I'm looking, I'm thinking. You know, I was taught once, if you see a black hole and you move it, the trachea left to right, if the hole moves, it's probably the airway. If it doesn't move, it's probably the esophagus. And so my right hand is always there until I'm ready to grab the tube. And if it needs to be moved, then I grab someone else's hand and I physically put it where I want them to hold it and say, do not move. So I do every time.
And the beauty of video laryngoscopy is your assistant can see what you're trying to do, and you get it where you want, and then you put their hand on there, and they know what they're doing. They know where they're holding it, versus just blind pressure and hoping it's right. So another plug for VL.
This ties into the comment that Randy made about lazy positioning, because I think, yeah, probably manipulation with the larynx would help in this case, but also the video scope is pointing at the left piriform sinus. It's not advanced far enough in the airway, so I would first start with those maneuvers before I just try to like shove the airway into my view. It's helpful, but it shouldn't replace the tenets of good laryngoscopy.
Yeah, I totally agree with Chris on that one. I saw Randy's comment too, and I do feel like video is making us lazy positioning airway gurus 100%. So I feel like that's something we have to be very cognizant of as we use video.
Not lazy using the Mac 4 for every airway, right? Just lazy for. Okay.
Is it just positioning?
Just position. Okay.
Yeah, I think we've talked about this before. Video laryngoscopy has made it to where you can get by with bad technique for quite some time before you have an airway catastrophe, and you can get by with VL with some bad techniques, with some bad habits, and then eventually you're going to face catastrophe. So even you still got to do everything right every time, regardless if you got poor positioning. You're like, I think I can get it right thing every time.
Fantastic. And finally, last case, this was the person in the MVC who Terren snaked us and didn't tell us that he was nasotracheally intubated, but we figured it out anyway. And then they went to go to do a definitive airway, and we just see lots of blood in the airway. So there, right there, you can see the nasotracheal tube, and now I assume they're trying to get it out and put in the definitive airway. What did we take away from this? It's been so long ago.
Yeah, I think I would probably, if this person needs other things immediately, I would leave that tube there. I mean, it's past the cords, it's in the right spot. It sounds like they need some other interventions focused on. I would leave that airway alone for the time being.
You think like the hypotension, the 60/40, maybe that?
Something about that, yeah.
I know.
Yeah, maybe some blood products and good access.
Yeah, the enemy of good is better, is what I've always been told. And sometimes, in critical care and emergency medicine, try to do too much. So take a step back and ask yourself, are we good? Are we good right now? Or are there other things to do? Chris, Steve, anything else on that last case?
No, agreed. Stay high and dry if you're using VL and a contaminated airway, and yeah, great points.
All right, gents. Well, we've gotten to the end of the program. We even went a little bit over, but you know what? Totally worth it. Totally worth it to hear you airway gurus talk about some of these cases and get your perspectives. So I truly appreciate you being on. Adam, what do you think? Was this like the best show ever?
I loved it.
Yeah.
We should do it again next time.
Yeah, for sure. I mean, if people really respond and they give us a thumbs up, then we should do this airway hot seat a lot more frequently. And then once we go live, we can even do demos and things like that. We're setting up the studio to do all of that. So, gents, Chris, guy in the middle, and Terren, I really appreciate you being here today. Really, it was an outstanding show, and thank you again.
Thank you, guys.
It was a lot of fun. Thanks.
Yeah, thanks. A lot of fun.
Appreciate it.
Thanks, guys.
Episode 8 in the books, Adam.
Done.
These shows are getting better and better.
Done.
Yeah. Once I can remember to unmute people, it really it sounds pretty good.
Yeah, I love it.
No,
So I was thinking about something you mentioned.
Yeah.
You said something. You said I would really like to meet this Randy guy,
Really
and
would
so
be Randy.
and so then I thought we should invite him, but then I thought we would have no comments. He's like 90% of our comments, and so
I think Randy
so this
is
is an
in Indonesia. I don't even know if Randy. You know Randy? Does he exist?
oh yeah,
Oh,
yeah, he's
okay.
real.
Is he
he's real.
tall?
Yeah, he's pretty tall. He's
Yeah.
pretty tall. Bald.
Is he
He's bald.
A bald, like intentionally
Bald.
bald or bald? You know, bald.
I don't know the answer to that.
Okay. Well, then I think we have to meet Randy at some point. Or, we'll have to see. We'll take a vote because it is good to have that person out there who's this mythical character who no one ever
Yeah.
gets to meet,
What I was going to say is if everyone comments a lot next episode, we may be able to bring Randy on.
Oh, I see. Okay.
See what I was doing there?
I saw what you did there. Very well done. Very well done. Well, Adam, as always, it's really, really good to have you. 2 weeks from now, we're on this rhythm now that we're going to stay every 2 weeks. So I can't tell you what we're going to do next, but we're going to pick a show very, very soon, advertise it. So plan on 2 weeks from now. What is that going to be? The 9th plus 7, the 16th? February 16th?
And if numbers keep trending down, we're getting closer and closer to
Yeah.
being live, I think.
Be in the
I
studio.
think
It's very, very
we're
cool.
almost there.
Almost there. Well, good. my
Maybe
friend.
March.
Yeah, for sure. Well, listen, everyone, thank you so much for being here. Again, please like this video, subscribe to the channel. It just shows us your love and also helps to improve the algorithm so that more eyeballs get to see this. And I really, really appreciate it. I just keep reading Randy's comments. I have to turn them off. I'm done with you, Randy. I'm done with you. But really, thank you for being here. The response, the comments, the notes that I get about the show, I'm really grateful that you all are tuning in, and I can really feel that you all are learning something. So thank you for the support. Adam and I really appreciate it. And we're going to see you next time on the Critical Care Lounge. Adam, I'll see you soon.
Be safe, everyone.